Hello everyone, and welcome to this first webinar session in the series on achieving and maintaining maternal and neonatal tetanus elimination, the last mile. This series is hosted by the WHO Department of Immunization, Vaccines and Biological, in collaboration with the UNICEF Health Section, with the support of TechNet 21. First of all, a few housekeeping items before starting this session. Please note that this webinar is being recorded and that we will share with you the links to the video and the presentation slides later on by email. This session is also interpreted into French. If you would like to switch languages, you can click on the interpretation icon and you can select the language of your choice. The interpretation icon is at the bottom of your Zoom window. Feel free to introduce yourself in the chat. Tell us your name, tell us where you're from, and you can also use the chat if you need any technical support. If you have any question during the presentation, please use the Q&A box, which is also available at the bottom of your Zoom window. Feel free to ask your questions at any time, and our panelists will answer throughout the presentation. Our moderator will also ask you directly at specific moments of the presentation to share your experience with our panelists. During these moments, you can raise your hand by clicking on the raise hand icon at the bottom of your screen, and the moderator will unmute you so you can talk. I hope you enjoy this session, and now I will give the floor to Nasir. Nasir, the floor is yours.
Thank you very much, Gigi. Let me start by welcoming all the participants to this, the first series in a series of webinars that we've organized, as Gigi mentioned, organized by WHO, the Immunization, Vaccine and Biological Department, and then in collaboration with the UNICEF Health Section, the Immunization Department within the UNICEF headquarters in New York. Now, before I give a quick background, I would just like to apologize to our colleagues who are connecting from countries with time zones where they have to be up very early in the morning, and those who are connecting from countries in time zones where they probably are connecting very late into the night. We tried as much as possible to balance the possibility that everyone will be able to participate given the different time zones. Having said that, as Gigi mentioned at the beginning, we've got the main presenter who will be presenting the slides, while we have a moderator who will be moderating. The moderator is Francophone, so it should be, her interventions will be in French. So please, for those of you who don't speak French, as soon as the moderator is speaking, go to the English translation so that you can follow her. And the presenter, Dr. Mokuolu, is Anglophone, so she'll be making the presentation in English. Those of you who are more comfortable in French, as Gigi mentioned, please go to the French interpretation. Now, this webinar, as I said, is the first in the series of 3 webinars, as you may have seen in the advertisement of the webinar. Now, the objective of the webinar is to ensure that we have adequate technical capacity at the country level to be able to plan, implement, monitor, and evaluate with very high quality MNTE activities aimed at achieving elimination in those countries that are yet to achieve elimination, and to sustain elimination in those countries that have been validated for elimination. As most of you will know, we have 59 countries that were identified in 2000, in year 2000, after the World Health Assembly resolution that neonatal tetanus should be eliminated as a public health problem. Between 2000 and today, we have 49 out of the 59 countries, representing 83% of the countries having been validated to have eliminated maternal and neonatal tetanus. We're left with 10 countries. These 10 countries are mostly countries that have one form of insecurity due to conflict or due to other causes of insecurity in the country. Therefore, implementing MNTE activities like every other health activities or social services delivery are quite, it's quite challenging in these countries. And therefore, the need for us to make sure we have adequate capacity at the country level. Again, over the years, there have been a lot of turnover within the different, whether in the Ministry of Health, in WHO, UNICEF, and other partners, and therefore the need for this capacity strengthening series of webinars. The first webinar that is taking place today is on the epidemiology, the pathophysiology, clinical features, treatment, and management of neonatal tetanus. We also touch a bit on non-neonatal tetanus because we know that in most of the countries that have been validated, the 49 countries that have been validated, while the incidence of neonatal tetanus have gone down, we begin to see a rise in non-neonatal tetanus, especially among older children. And this is of concern to us. While the focus of this series of webinars is on neonatal tetanus, we'll also be touching a bit on non-neonatal, including tetanus generally in adults. After this session, the next session we'll be looking, in 2 weeks' time, we'll be looking at the other components of the global initiative. So having said that, I'll hand over the floor to the presenter, Dr. Mokwolu. But before I do that, just to say that as we go through the different aspects of the presentation, starting with the epidemiology and pathophysiology, we'll be pausing at each interval to get the experiences of colleagues who are participating, their different experiences with this aspect of the presentation, the epidemiology and the pathophysiology. The presenter will also be sharing her experience from her home country and other places where she has worked. The moderator is a veteran MNTE colleague who has supported MNTE activities, especially validation in over a dozen countries, mostly across the African countries. So she'll also be sharing her experience. With that, I would like to give the floor to Dr. Mokwolu to take us through the presentation. Over to you, Dr. Mokwolu.
Thank you very much. Good morning, good afternoon, good evening, from wherever we are all listening from. I'm Dr. Mokwolu, right teacher, that's University of Ilorin Teaching Hospital, Nigeria. This morning, we are going to go through the neonatal tetanus using the outline, the epidemiology, pathophysiology, clinical features, and management. Next slide. By way of introduction, tetanus is an acute infectious disease. What we call acute and infectious, it is not contagious. That means you cannot transfer, it cannot be transmitted from person to person. But it's infectious because it needs a contact medium to be able to transmit it to the individual that is affected. And it's caused by the toxigenic strains of this bacterium called Clostridium tetani, which is an anaerobic organism. That means they thrive well in an environment where there is no oxygen, there is lack of oxygen. And for tetanus to be present, or the organism to be found in the environment, that means the spore must be present in the environment irrespective of the location, that's geographical locations. And for the pathophysiology to be made manifest, the spores enter the body through contaminated skin wounds or tissue injuries, usually from puncture wounds or penetrating injuries. But for the neonate, it's usually from what? Maybe poor cord care, or even poor or unsterilized instruments used to cut the cord during delivery, or even from our cultural practices, such as hot fermentation using to care for the cord while these babies are being cared for. Tetanus usually can occur at any age. That means no age is spared. Both adults and children can be affected. However, the case fatalities are usually high, especially even when the intensive care facility is made available. However, in the case of absence of medical intervention, the case rate can be as high as 100%. So it's not a disease that should be treated with levity. Also, it remains an important public health disease because usually we talk of tetanus as a problem of what? Poverty and ignorance. Just as been said, it's a problem of what? The low-income countries, where immunization programs have been suboptimal for different reasons. Maybe because of insecurity or the hard-to-reach areas from wars and even ignorance from our cultural practices. Next slide, please. The tetanus surveillance is not well established in most countries, but it is preventable through immunization with tetanus toxoid, which is one of our immunization programs. We find out that tetanus usually come with either the DPT, that's the diphtheria, the pertussis, and the tetanus combination vaccines. These vaccines contain the tetanus toxoid containing vaccines, and as well as clean delivery has been found to be ways of preventing. That means our delivery processes must be made to be what? Clean and safe. And our core practices in settings like ours, we have some funny cultural practices that people do while caring for the cord, such as application of hot fermentation, cow dung, or even as well as using of methylated rub to care for this cord, which serve as what? Needles for the tribe of these organisms. If these wounds are not properly cared for. For the older age group, surgical or dental procedures which are not well cared for are risk factors for tetanus to occur. However, in countries with high coverage of these vaccines, tetanus incidence have been found to be very low. And so that is to tell us that countries where immunization programs are optimal, the risk or the incidence of tetanus are usually what? Low or next to none or zero. While for those that have poor immunization history or are not even immunized at all, then these individuals are at risk of having the tetanus infection. However, over the years, instead has been said to reduce. Why? Because people have been targeting children and pregnant women with this vaccine, thereby trying to optimize the routine immunization programs in them, thereby reducing the risk of tetanus. Next slide, please. However, in low-income countries, most associated tetanus are usually among women who have been insufficiently vaccinated and their newborn, following what? Unhygienic deliveries and abortions, which are usually what? Unsafe abortion procedures, and poor postnatal hygiene, and as well as the cord practices. Just like I've said, in our setting, some of the poor cord practices are use of what? The cow dung to actually care for the cord, as well as even some use as what? Toothpaste care for this cord of these children. And the sloths are usually so dirty when they come, and this serves as a portal of entry for this infection. Why for those, the male neonates are those with poor unsterilized instruments used in circumcising them, as well as even poor cord care, using unsterilized instruments to even cut the cord, or instruments that are not clean to cut the cord. This serves as needles for this infection to thrive in them. Also, deliveries are carried out just with unclean hands. People don't care about having the environment to be clean, even in taking deliveries for these mothers or even the babies, or the surfaces are actually contaminated. All these ones pose risk factors for the development of tetanus in them. However, for those that the countries have been able to have the reduced burden of this neonatal tetanus through vaccination. A lower proportion of percentage can still have the infection, maybe as a result of injuries, especially in children, puncture wounds, or even infected surgical wound sites, even in adults, can also be a risk factors for them. Next slide, please. In settings where the coverage of the immunization has been low or has not been, and the high coverage has not been achieved, that means there's a gap between the for immunity that exists. So therefore, the newborns are not protected from having this tetanus. So we should target the pregnant women or the teenage mothers who are planning or preparing to get pregnant to have the immunization or the vaccines. Next slide, please. Okay. Pathogen that we've been talking about, that's the Clostridium tetanus, is a gram-positive spore forming. That means it forms spores and it thrives strictly in anaerobic environment. That means environment whereby there is lack of oxygen, the organism is said to thrive well. That means oxygen does not support the growth of the Clostridium tetanus. And for there to be the infection, the spores must be present in the environment, usually in the soil or moist environment, and even may be carried in the intestinal tract and even feces of humans and animals. Just like I said, at times these feces are used to take care of the cord of these children, so thereby penetrating into the umbilical cord stump into the bloodstream of these children. Untreated soil, just like I said, it can be contaminated because the manure is still part of the animal or the human feces, which can serve as what? Risk factors or means of transmission for these organisms. When the Clostridium tetani enters into the human cells body through the portal of entry, it will be from commonly in the newborns, usually from the umbilical stump, or even from the point of circumcision. For the ladies, for the female babies, even from the point of what? Piercing, in terms of either the hair piercing or even body piercing. And all these unsterilized factors are used for the children. For example, just like the cow dung or use of poor or dirty rags to clean or to do hot fermentation for these umbilical stumps. These enter into their body or the contaminated wound from penetrating injuries, usually for the older ones. When it happens, it enters and it goes straight. It has the means of going into the body system. How? When it enters, the bacteria enter through the wound, then it is absorbed by the peripheral nerves and transported to the central nervous system of these children or the individual. The toxins now, what do? They inhibit the release of neurotransmitters at the level of the neuromuscular junction, and especially glycine. The organism at this toxin is what? Tetanus spasmi. That is usually more notorious for this exhibition of these effects on the children. And what happens? Once it inhibits this release of these neurotransmitters, it causes what? Muscular rigidity. And usually it can affect any part of the body. If it's to the back, that is why we have the muscles. There's this spastic presentation of the babies with hacking of the back, looking as if they are pushing themselves forward. And this leads to the spasms that we find in them, and they are usually sustained contractions. With all this further causes spasm, and once there is spasm, this can cause what? Respiratory failure, because the child can be having difficulty in breathing. There could be what? Even to the muscles of the body, that is, I said, there'll be hacking of the back, and as well as even death if not well treated on time. Then the site of usually for the older ones, by the time they are coming, the order of entry is usually unknown. But from our history taking or even examination, we can find areas of healed wound injury, recent wound injury being healed rather, not long-term wound scars. We look for recent signs of healing around them. But for the newborn, it's usually more of the most common portal of entry is usually what the umbilicals. We usually find the stump. They are usually dirty looking or foul smelling. For the males that have been circumcised, we hear of history of recent circumcision, and if for the piercing or even the tribal marks, can find all these marks on them based on our examination. I said earlier on that tetanus is not transmitted from person to person. That means it is an infectious disease. However, it is not a contagious disease. Next slide, please. Now, the toxin is the tetanus plasmid, which I said is blocks the in vitro neurotransmitters, and it causes the spasm and everything, and the muscular rigidity that is usually seen in these children. However, the other toxin is the tetanolysin, but the most potent of this poison is the tetanus plasmid, which usually lies the bacteria and spread the release they are the ones that can cause the toxins that are most potent and most dangerous of the two toxins released by the bacterium. Next slide, please. Okay. At this junction, we can take a little break and ask our questions on epidemiology and pathogenesis. Thank you.
Okay, thank you very much, Dr. Mukolu, for the presentation on the epidemiology and the pathophysiology of tetanus, particularly neonatal tetanus. Now I'm going to hand over to the moderator, Dr. Kosia Yao, who will be posing, request for.
Thank you, Doctor, for your presentation. Thank you, Dr. Yusuf. Thank you for giving context. Thank you for telling the history and all the progress we've made towards the eradication of this illness. It is a public health problem. With your presentation, we were able to understand in a clear manner that neonatal tetanus is a public health problem. However, we can avoid tetanus. We can avoid it thanks to vaccination and thanks to healthy birthing practices. And through umbilical cord healing and care. Now, of course, in low-income countries, incidence stays elevated. And also when birthing takes place in poor hygiene standards. Doctor, you also showed us that the adult can also contract tetanus because of wounds. And when the unvaccinated adult gets wounded, or when young girls or young boys, because of piercings, or other practices, can get tetanus if they're not protected. The pathogen liberates a toxin, which is a strong poison. And it makes a link with the next part of the presentation, thanks to muscular rigidity.
Dr. Kosia.
My apologies. As I was saying, you have the floor now. I don't know if you've heard the last part of my intervention.
Dr. Kosia seems to have some connections issues.
Yes. Okay. So I think she's laid down the groundwork for this. And so, like I said, what we'll do first is to ask the presenter to share her experience with us in terms of the epidemiology, if from her experience, clinical experience as a pediatrician, if there are things that are a bit different from the epidemiology we've highlighted here from our own experience. And then we'll, like we said, give the opportunity to one or two participants to also share their experience in terms of the epidemiology and the pathophysiology from their own work experience, especially in their countries. Because of the number of participants, we may only be able to
you can raise your hand. There are still no questions. Please use that to the greatest extent to ask your questions. If you have questions about this part, you can raise your hand and we'll give you the floor.
Please raise your hands if you want to share your experience or ask questions or comments regarding the epidemiology and the pathophysiology of tetanus.
I don't see any questions. Maybe Dr. Yusuf, we can continue on. Maybe the next parts will generate more exchange with our public, our audience. I see a question, can we share the PowerPoint? As mentioned before, it will be shared by the end of the presentation. We're gonna give the floor now, but I'm forgetting, I'm Dr. Kozia. I have been fortunate enough to live in a country where the elimination of the neonatal tetanus has been approved. I'm currently in Ivory Coast. So I'm going to give the floor for the next session. Thank you very much, Dr. Kosia. We're going to go back to the presentation again.
Dr. Mokwolu, I think we can continue with the presentation.
Yes, thank you very much.
Okay, so I'm trying
Next
to.
slide, Dr. Yusuf.
Yes, that's right. There's some hitch here.
I see a raised hand, but you'll have the floor on the next session because we have already given the floor to a panelist. Mr. Akimola, you'll have the floor on the next session. Thank you very much.
Gardez votre question.
Okay, merci beaucoup. Dr. Mokwolu, please continue.
Thank you
with the
very much,
presentation.
everyone.
Yeah.
We'll continue. Well, with the disease neonatal tetanus, let me start by saying that it is a generalized form of tetanus, the neonates. Why? All the parts of the body or the muscles are involved. Unlike there's other part of the what? The localized form, but the neonatal tetanus is a generalized form of tetanus. And in about 90% of cases, the signs and symptoms usually they can be as short as 3 days and could be as long as 14 days, with an average of 7 days after birth. The import of this, the shorter the incubation period for tetanus, the worse the prognosis. That means for the child to have the manifestation of the disease, of the infection as early as possible, as early as the first 3 days of life, shows that the prognosis is poor. However, the mothers coming into the emergency room with the history of the child either unable to suckle and previously has been suckling well from the breast. However, and some can even come with apnea, that is the child forgetting to breathe, not because the child doesn't want to breathe, because of the sustained contraction, the laryngeal spasm, and the respiratory involvement. The child usually just go into a state of apnea, and they come in as a cause of what? Emergency. For some, they can even come with sustained what? Spasms. That's generalized spasm that the whole body is into like an attack on the back is hard, and it's not because they don't want to do anything, because of the effect of the what? The toxins have been disseminated. And of course, facially, the child looks like Steve smiling, given the typical form of the rhizosis sardonicus just talking about what the devil smile. As adults, we know what it means when we don't want to smile, but we smile in such a way that it's sending across a message. So the child usually, or the baby comes with this kind of smile because of what? The facial muscles are involved, and the spasm. There's like it's sustained contraction of these facial muscles. And so these babies come with what? Rhizus sardonychus, and it gives them like a form of an expressionist fasci on the face, and looking as if they are forcing them to smile. Well, in the real sense, they are not smiling. It's just the effect of the toxins. Next slide, please. These spasms are sustained. That's the hard part that I've talked about. Is called the clinical and the classical word is what the hospital-tonus posturing. However, this is not limited to. It is not diagnostic of neonatal tetanus. There are other disease conditions that can give the hospital-tonus fascia, which is the backward arcing of the heart, the head, the neck, and the spine at the back. And once these children or these babies are touched, there's a sustained contraction as if they are just going into another form of spasm. And this is another reason why we talk about nursing them in what? In quiet environment. Even noise can stimulate all this sustained persistent muscular contraction. And we talk about minimal handling in them. Where spasm involvement of the glottis, this can lead to what? Sudden death in them. And we talk about the case fatality rate can be high as 10 to 70%, depending on what? The age at presentation, the treatment given, the longer or the more they delay in assessing healthcare, the poorer the prognosis, or even leading to the mortality. The presence of what? Or absence of other comorbidities, then this will also worsen the prognosis of the child. We'll briefly talk about our experience. Neonatal tetanus usually have very poor prognosis because they come late. They have other florid symptoms that they present with. In our setting, I usually talk that the neonatal tetanus in children is a problem of what? Yeah, ignorance or even insecurity that I've talked so much about, or even poverty. So some are actually coming as a result of what? Delayed presentation based on financial aspects and the cultural practices that we do around us. I work in a tertiary center, and I tell us for each case that I've seen, I call it the tip of the iceberg syndrome. There are thousands there, either have gone to the primary health center or the secondary health center, that we are not having data in terms of their own presentation or even the outcome. So next slide. Thank you. Now, the neonatal tetanus that we are talking about, this can, you know, there are risk factors for it that I've talked about. It could be usually what? From the mothers or the caregivers. That could be from the pregnancy, prenatal, that's even before delivery, natal, and even after delivery, that all those practices can constitute risk factors for them. One, no attendance of antenatal care during pregnancy. In some settings, some mothers will tell you that they've never had any form of antenatal care during pregnancy. Those ones, they are at risk of not having any form of immunization or vaccination, whatever, as soon as small as it might be, to help them to really curb this disease progression. So such mothers are at risk of what? Delivering at home. And when they deliver at home, they are at risk of using what? Sterilized instrument, cutting the cord, and also what? At risk of having what? Poor cord care at home. All these use of hot fermentation, rags, animal feces, or even human feces to even care for the cord, as well as even using human feces to even care for this cord. I said for those that don't have the antenatal care, some have antenatal care, but they have what? No or incomplete vaccination during pregnancy. This is another risk factor. Some they come for antenatal care maybe in the third trimester or a week to even delivery. So they will tell you that they have not even had maybe just a dose or no dose at all, even in the index pregnancy or previous pregnancies. Because I've talked about delivery. Delivery done or conducted outside the health facility. or especially at home, under unhygienic or unsterilized environments, poses as a risk factor for the what? For the tetanus to happen in such babies. Because delivery at times can even happen in the hospital. For those that have delivery by unskilled attendants, maybe relative traditional birth attendants, some who as far as delivering even in religious facilities, all these things are conducted under unhygienic conditions or situations. This won't serve as a risk factor for the development of neonatal tetanus in these children. Talk about no attendance of postnatal care in terms of what should be done even at delivery and post-delivery, exactly postnatal care for the mothers, not only just the babies, because even the mothers too can develop what? Tetanus, if not well taken care of. But for the children and for the babies after delivery, teach them about the good cord care, circumcision in terms of being done under good hygienic environment, not just going to anywhere in terms of unsterilized instrument being used for these children. As we talked about the umbilical cord, so this is the major portal of entry for these neonates, and it can never be overemphasized. People coming in for cord care, I've seen a baby brought in using toothpaste as a form of cord care with hot rag to care for this cord, and this baby came down with neonatal tetanus. These are unhygienic cord care practices. Some talk about some cultural practices, use of hot fermentation stones. Stones are not even sterilized. You don't know where they are coming from. Some people, after the stump of the cord has fallen off, the cord has fallen off, some people tie it into a rag. Those are harmful practices. Tie it into a rag and keep using it every morning to care for this same cord. Some cords become infected. The mothers don't know that they will just enclose it again with plaster, thereby enabling the proliferation of the spores in these children. Next slide, please. So Nasser, next slide, please. So please, the video clip of the case of neonatal tetanus will be played to us. And after that, we have our question and answer session again. Thank you very much. This is the hacking of the back that we talked about. This is the child having spasm.
Thank you very much. I think we can continue, Dr. Mokwana.
Okay, no question.
So this is...
Dr. Mokolo, thank you very much.
Welcome.
For all these reminders of clinical features. The disease has become more rare and it is not very well known. And that's what makes it so serious, because the diagnosis is difficult. So these reminders are really important for us and for the whole of the players who intervene on the child or on the adult. And before I hand the floor to the person who raised their hand, I just want to remind you that tetanus, the clinical signs after contamination, the symptoms appear after the 14th day, and it's rarely localized. The toxin that is spread in the organism and the generalized symptoms can reach all the muscles, respiratory muscles, etc. And we have those signs in which the baby's back is arched, and like we've seen in the video. So we need early diagnosis to monitor the evolution of the disease and prevent the fatalities. And prevention begins at pregnancy, and even before pregnancy, I would say, through raising awareness of the health personnel in terms of vaccination and for the care to the umbilical cord. And we also need to raise awareness in women so that they can get their vaccine dose before the birth. We need to raise awareness as well in terms of umbilical cord care in the home, because if you use contaminated objects, that's a risk factor. And I wanted to highlight the fact that some cultural practices that we've seen in many countries, practices that really promote the spread of this disease. Sometimes any substance that you can imagine is applied, whether it's cow or zebra excrement. And when you know that the bacteria lives in the soil, these practices are really put the child at risk. So now I'm going to hand over the floor to Mr. Ake Kogola so that he can ask his question. And you can activate your microphone. Otherwise, we won't hear you. Mr. Kehinde Akinbobola, you need to activate your microphone. Please turn on your microphone if you want to ask a question. For the moment, we don't have any question, but there's a raised hand, and I've sent you a message that you activate your microphone so that you can speak.
Okay, for the sake of time, maybe Mr. Kande can put his comment or
Thank you. You can put it in
question.
the chat box.
Yeah, in the chat box. Look like it's having problem on muting. Okay. Again,
if you can, write your question down and we'll ask the question to the panelists. Are there any other questions? And he wrote to thank the speaker for this presentation. So we might as well move forward, I think.
Okay.
If we don't have any more questions, then we can proceed.
So I would like to emphasize the objective of this presentation. As you'll notice, it's all about the clinical feature, the epidemic, especially the clinical feature. Why we decide to emphasize this, place emphasis on this, is because, as we said earlier on, as countries continue to develop and strengthen their immunization systems, as they continue to strengthen their maternal and newborn health systems, so that pregnant women have access to tetanus vaccines during antenatal clinic or any other platform, and that they have access to skilled birth attendants with delivery under hygienic conditions, and that they follow the global standard for cord care practices. We begin to notice that the incidence of neonatal tetanus becomes so low that young doctors, clinicians in such countries, some of them may not have seen cases. So we hope that the clinical feature we've seen here, supported by the video clip, may help as a reminder, so that in settings where this disease is no longer common, at least we have a visual image of, visual understanding of what it is, so that when we unfortunately have a case, we shouldn't miss the case. Thank you very much. Back to you, Dr. Mokwolu.
Thank you very much, sir. We'll continue.
Yeah.
Just like I said earlier on, that there could be neonatal tetanus. If there is neonatal tetanus, tetanus occurring in children units 0 days 0 to 20 years. The older age group, they are the what? The non-unit group. That we permit me to use that word. So they are the what? And non-unit group. That's children above 28 days. So that's the people that can fall into this particular group of the non-neonatal tetanus. And just like I've said, the incubation period can be, their own incubation period too, can be as short as the 3 days and could be as long as what? 3 weeks. That is 3 days to 3 weeks or even more. But the shorter the incubation period, the worse the prognosis in them too. And the median interval between the entry of the organism and the onset of symptoms is usually 7 days. However, it can be longer than that, even after 178 days. However, the portal of entry in non-neonatal group is not going to be the umbilical cord. Why? Because at that period, we expect the cord to have healed, and so they have other portal of entry. And said that the farther away the injury site or the portal of entry to the central nervous system, the longer the incubation period. For this older age group, they are usually more of puncture wounds, maybe nails usually from the leg, or even fractures or surgical sites, or even a fall that had a wound that was poorly treated. And this depends. That means the children, that's the brain children. Otitis media is another risk factor, that is infection of the hair, in which the organism can invade and can get entrance into the central nervous system. And those children or those group with this particular portal of entry, that's from the hair, they have a shorter incubation period compared to those that had the puncture wound from maybe the leg or from nails around them. I said earlier, the shorter the incubation period, the higher the mortality rate or the worse prognosis. And they have majorly 3 presentations, either the localized as usually affecting the part, that is a particular part, the cephalic, that is the head, or the generalized tetanus as involving the whole body. Thank you very much. The next slide, please. The cephalic part, are usually more of the portal of entry, is usually in older age group, the hair, that's the causing otitis media as tetanus complicating it. Localized tetanus is really not too common, and it's just presentation of characterized by the sustained contraction of the muscles of the particular area that is affected. It is a rare presentation, and the presenting complaints are usually with early spasm or sustained contraction of the muscles that is affected, and it's usually, like we call it, the trismus sign of the jaw lock. You know that the trismus sign is an inability to open the mouth, and the jaw is said to be locked because the patient cannot open the mouth very well, and so this particular patient will have difficulty either in swallowing or even in chewing or even taking food. So they have the lockjaw sign that we talked about, the trismus that we usually call it. Among these patients are what? Among patients in the youngest and old ages group, the case fatality could be as high as 100% because of the organism that is involved, and the maybe portal of entry is close to the central nervous system. Next slide, please. So for both neonatal tetanus and even generalized tetanus, or the non-neonatal tetanus, the diagnosis is clinical. What do you mean by clinical? Those are the bedside signs that we can see what the patient is eliciting. Most common bedside sign that we see in these children are usually what? Spasm, or the sustained muscular rigidity, that we can call it the autotonal sign. And when we move close to them, they could have what? The periodic spasm that they present with. And does not usually depend on presence or absence of lab findings or confirmation. Sometimes every time we are having evidence of lab confirmation, laboratory confirmation, there may be because there are presence of what? Other confounders like infections or even electrolyte derangement that could happen in them. So by WHO definition, finds it as either a suspected case or a confirmed case. What do we mean by a suspected case of neonatal tetanus? So a suspected case, all the newborns that have, upon delivery, they've had ability to suckle. That means they've taken breast milk from their mother and they've cried normally, usually before presentation, the first 2 days of life. However, post-second day or even 72 hours of life, depending on the incubation period for the child becomes irritable, crying excessively, and then subsequently stop to suckle from the breast. And some even die within between the third day, that's 72 hours to 28 days of life, which marks the end of the neonatal period. Or newborns that died from unknown cause during the first month of life. That's the definition of a suspected case by WHO. And what is the confirmed case of neonatal tetanus? Is defined as the neonatal tetanus case as an illness that has occurred in the newborn or a neonate who has normally had ability to suck, cry within the first 48 hours of life. That is the 72 hours of life. And then subsequently would lose this ability between the 3 and 28 days of life and has had evidence of rigidity or spasms that we have witnessed. I hope we are able to get that. That's the next slide, please. That's the WHO case definition. Now for the non-neonatal tetanus, the WHO definition of the adult tetanus requires at least one of the following signs. That's the trismus or the rhizus sardonicus, that's the devil's smiles that we have earlier talked about. Muscular contractions comes in as spasm. However, before we can have this definition to be established, there could have been history of wound injury in the patient, or the patient might not be able to recall a particular wound injury, but however, when we check along check the body, we can see evidence of maybe a wound just previously starting to heal. So that might give us an idea. Now, what's the clinical test that we can do or can be performed? That's called what? The spatula test. It is done to make a diagnosis in tetanus, and it's done by just having a reflex spasm of the jaw in response to touching the posterior wall of the pharynx with a soft instrument. Why soft? So that will not inflict injury to the particular to the patient. So by the time we have this, by the time we put the soft instrument into, you can use a wooden spatula for all it works. So that when we put this to just at least stroke or touch the posterior wall of the pharynx, we have a reflex spasm of the jaw, and this gives us a positive spatula test. And then we could actually make a diagnosis of tetanus. The test is said to be what? Is 100% specific and 94% sensitive. Next slide, please, on diagnosis. Now have question and answer to be made, but overall, diagnosis of tetanus is majorly a clinical diagnosis. Thank you. Yes, Dr. Yusuf. Hello.
Okay, merci,
Kosia.
docteur, pour ce rappel sur les signes cliniques et le diagnostic. Comme je le disais, c'est une maladie qui devient de plus en plus rare. Et ces rappels sont importants.
Let me remind you that tetanus can occur at the adult age with an incubation period lasting from 3 to 21 days with extremes. We mentioned a number of 178 days. You'll agree with me that at this stage, if a wound occurs, it will not get visible later on. We were also reminded that the shorter the incubation, the higher the lethality rate. Tetanus is also rarely localized. The last sign is obviously clinical, so it is very important that we get to know those signals. In the adult, there is trismus and spasms, even though, as it was mentioned several times, a prior wound can, or rather an absence of wound cannot be considered as a definition, because it could have been cured when the symptoms appeared. I have recently witnessed 2 cases of tetanus with adults, and I can say that it is really clinical. Those cases are easily recognizable. I was unfortunate enough to witness a dozen neonatal tetanus cases. It is very hard to see. Earlier on, when the video was broadcasted, I looked elsewhere because it was really unbearable to see. We could see the baby screaming. It is really difficult to see. We have to be careful because it's a disease we can avoid thanks to vaccination. We can also avoid this thanks to campaigns, thanks to information campaigns. We also have to avoid malpractice in our houses. We have also to inform the healthcare workers. Indeed, we have the trust of the mothers, and when they come to get in labor, we need to sterilize all the instruments involved to avoid such awful situations. I still see no raised hands. If anyone has already witnessed a case of adult or neonatal tetanus, you can have the floor and share the experience with us. As I said before, it is a rather rare disease, but we can eradicate it thanks to vaccination. As has been said, it lives in the soil, so it cannot be fully eradicated. So if people are not protected enough, the speaker has unfortunately left.
I'm still here.
Dr. Kosia,
I'm still here.
Yeah, okay. So, merci beaucoup, Dr. Kosia. Dr. Mokolo, before I give you the floor to continue, I just wanted to emphasize this aspect of the presentation. As I said, the incidence of neonatal tetanus has declined significantly in most of the countries, given that we have only 10 countries left globally.
Je suis de retour, merci.
Thank you very much, Dr. Kosia. I'm doing an intervention. Thank you very much.
Yeah, so as I was saying, so the incidence had dropped drastically. The last couple of slides we saw, or the diagnosis, I think it's very, very, very important. The WHO diagnosis of suspected case and confirmed cases are those two diagnoses are very important, especially for the surveillance. As Dr. Mokuolu mentioned in her initial presentation, and as emphasized by Dr. Kosia, the surveillance for neonatal tetanus is one of the weakest. Actually, it barely can detect up to 10% of the cases. So most of the cases are in the community. So if we use this WHO definition, for example, the definition of suspected case that says any newborn that dies of unknown cause in the first month of life. This is very broad enough. This is a definition that can be used by the layperson, even in the community. And if the community are aware that any baby that dies in the first 1 month should be reported for investigation, this is very important. It also gives the other definition of suspected case where the child was born normally, was able to suckle for the first 2 days, was able to cry normally, but from the 3rd day onward up until the 28 days, the child becomes easily irritable, ceases to suckle, and begin to manifest the other distance. It's very important that we report these cases for further investigation. I just wanted to make those lay those emphasis. Back to you, Dr. Moko. Look, we can continue with the presentation.
Thank you, everyone.
Okay.
Okay.
Just before continuing, I wanted to I think we've lost my intervention. As I was saying, we really need to be aware in terms of neonatal tetanus monitoring. It occurs in the when a baby gets infected, we don't notice it. It really goes unnoticed. Since we have a little bit of time, according to with the rest of the presentation, I just wanted to make a point on this. So, as I said, it is not notified to the health centers. We must insist on community surveillance so that we can identify all of the cases. As Dr. Yusuf said, in the literature, we cannot even detect 10% of the cases that occur in the community. That's what I wanted to say. Thank you very much. You have the floor for the presentation. Thank you very much.
Okay, merci beaucoup, Dr. Mokolo. Please go ahead with the next slides.
Thank you very much, everybody. I think we've gotten to the aspect of prevention. To me, if they will ask me that how would I manage tetanus, first thing I will talk about is prevention. Second one will be what? Prevention. The third one will be prevention before I will start talking about case management. Because prevention in terms of overall cost is a lot better and cost effective than managing a patient tetanus, and even the outcome matters a lot. And so we can say that prevention is what? The most cost-effective strategy against what? Neonatal tetanus as a whole. Why? And how are the ways in which we can prevent tetanus? One, advocate the vaccination of the pregnant women and women of reproductive age group with doses of the vaccine. And that's the tetanus toxoid vaccine. And how do we do this? We have to start with what? Surveillance, advocacy, making these people know the reason of need for the benefits of having this vaccine available and even taking it. Because availability of the vaccine at times does not mean that everybody will take up the vaccine given to them. Also, provision of children with their primary series of the DPT containing vaccine in everybody's immunization schedule. The DPT vaccine should be made available in them. The should be made available to them. The addition of booster doses, usually in the 2nd year of life, during school entry for them, and even early adolescents, should be made available. Other strategies for preventing neonatal tetanus include ensuring clean and hygienic delivery and not only delivery, even the core care practices, some of our cultural practices and addition of funny substances should be, parents and the caregivers should be counseled and made to know that these things are dangerous and they are not of any benefit to these children. Each time they come, or even public awareness should be readily available for these children, and thereby ensuring that the morbidity or the mortality of tetanus is brought to a low or more of a zero level in the affected countries, thereby aiming for elimination of this disease disease globally. Now, the strategies to be talked about at the next semi-webinar. So the next slide. Now, I've said earlier on that neonatal tetanus, even the non-neonatal tetanus, is a medical emergency that will require hospitalization, immediate treatment, and management as the case may be, because they usually come in with episode of sustained muscular rigidity, which are usually painful contractions for these children, or even the adults or those that are affected. Addition of the immunoglobulin is recommended. Why? This is to mop up the circulating toxins that are yet to bind to the neuromuscular junctions, thereby reducing or preventing further progression of the disease overall. But however, for those that are bound already to the neuromuscular junctions, this immunoglobulin has no effect on them. And he said that a single intramuscular dose is recommended where possible. And if it is not available, we can give the intravenous immunoglobulin. Then the equine-derived tetanus and toxin is said to be associated with what? Serious allergic reactions. And so should be used even as a single dose. But before we give this, there's usually a marked out part on the patient in which we give a test dose to what? To check for signs of what? Hypersensitivity before the full dose is administered to the patient. Antibiotics, yes, we give antibiotics in neonatal tetanus. This is not to mop up the toxins or to halt the effect of the toxins. However, we give antibiotics to actually help in what? Eradicating the possible what? Associated microorganisms that are being deposited in them. And usually the preferred antibiotics is what? The metronidazole, which is for the anaerobes or what? Penicillin G that is used. Next slide, please. There are the principles of management. Supportive care cannot be overemphasized. And this including what? You keep the patient in quiet environment to reduce the risk of what? The reflex spasm. That means you don't disturb them. It's minimal handling, especially the neonates. However, the pitfall of this is with the sustained contraction. There's risk of what? Accumulating secretion. So even when we are going to suction such patients, it's going to be done gently to avoid unnecessary stimulation of the spasms. Because for the feeding, we have to ensure nutrition can pass in a nasogastric tube to feed these babies for ease. The benzodiazepines that are usually used, they are used to control muscle spasms, and usually they are dose adjusted variations to actually accommodate to achieve spasm control without excessive sedation or even hypoventilation of these babies. However, if the muscle spasms are some really have uncontrolled spasms, it's critical to maintain a safe airway, because with this, if you're not careful, it can go into laryngeal spasm, you can have occlusion, which can cause apnea because of the secretion. So we have to maintain a safe airway. Where possible, mechanical ventilation could be used, but if not available, patients are usually monitored to actually minimize a spasm and autonomic dysfunction while avoiding respiratory failure, which is a major cause of death in them. Next slide, please. The non-neonatal cause said that both they are medical emergencies, and the treatments are usually similar. We have to follow usually the same principles of management. We have to prevent the development of tetanus after the contaminated wound. So those could be given to have immediate cleansing of the wound, and even properly or appropriate wound debridement where appropriate. And the immunoglobulins, usually of human origin, can be used in prophylaxis in case of the dirty ones or incompletely vaccinated individuals. for those that are not even sure of their immunization vaccination history. So just to err on the side of caution, and the age-appropriate vaccine is given as booster doses where recommended, especially for those with incomplete vaccination. For the full vaccination schedule should be made to be completed as soon as possible for those that have received that have not received rather the full dose on the basic schedule, in order to actually provide a long-term protection against the disease. Then, next slide, please. Now, tetanus has no naturally acquired immunity. So that means immunity can only be acquired either by a passive or active immunization. And for the fact that a patient has recovered from tetanus, it does not confer immunity. The immunity is usually an antibody-mediated type of immunity, and this depends on the ability of the tetanus-specific antibodies to be able to neutralize the toxin, which is the tetanus plasmid, when it occurs. And it's been said that very small amount of the toxin that is enough to cause disease is not sufficient enough to stimulate antibody production. So that means infants can be protected by both passive transfer from the mother when they are from the fetus, when they are given their immunization in pregnancy. So that means maternal sufficient vaccination, as indicated in the schedule, provides protection against these children, especially in the neonatal period. And that is why we cannot talk about prevention without talking about vaccination of pregnant women or women in the reproductive age group to prevent neonatal tetanus. Next slide, please. I think that is all. We welcome questions and answers from this particular session. Thank you.
Thank you very much for this presentation. We now know how we can prevent and manage tetanus cases. You'll agree with me that it is better to prevent than to heal from tetanus. Our presenter reminded us the prevention measures, most notably pregnant woman vaccination, but more generally, women who are in age to give birth, where the procreation period starts. Other prevention measure during giving birth has to be done in good hygienic conditions. She also reminded us that tetanus is a medical emergency. As I said, it is better to prevent tetanus than to heal from tetanus, especially in low-income countries. The healthcare structures are not always available. The presenter reminded us how we should do things, notably thanks to the distribution of immunoglobulin and antibiotics, who are going to be able to prevent the disease from progressing. There are also associated practices, most notably isolate the patient in a calm place with few lights and few noise to avoid the apparition of spasms. We also have to monitor respiratory activities because spasms makes breathing hard. So here's a quick summary. I don't see any raised hand or any questions that are asked. You still have the floor. I think that the objective of this session was to share experiences with all of the participants, to share your experience on this illness that unfortunately gets rarer and rarer. As it was said, a long progress has been made, but in some countries, it is a health issue that remains. In our region in Africa, even in places where it has been eradicated, there are still remaining cases, even if it's rare. And it would be great if this could be detected as early as possible, and that the management could be adequate in order to reduce the lethality rate. Does anyone have a question? The comments I see are mostly thanks and acknowledgements for the presentation. A lot of people are asking us to share the presentation, and we'll do it. The recording will be available. You'll have the presentation and the recording of this session before the next one. Do you have any comments, Dr. Yusuf? Or other panelists, do you have any comments?
Okay, so I think this is the end of the session, but just to emphasize that the last couple of slides sort of emphasize the the treatment and management of cases. For most of our colleagues at the country level that are responsible for MNTE surveillance and all the other strategies, this may not be of great interest to you, but the presentation will also help your clinicians, especially in settings where tetanus is no longer such a big thing. It might be of use to them. But what is important is that we've highlighted the importance of prevention through vaccinating pregnant women and women of reproductive age, and ensuring that children in their first year of life, they receive their their adequate doses of DTP containing vaccine, and that they also be given opportunity to receive boosters at the different ages, especially at the second year of life, and then during school entry between 4 and 7 years, and then early adolescence between 9 and 15 years. Now, as Dr. Mokuolu mentioned in one of the slides, the strategies for achieving elimination and sustaining elimination will go into more details in the next webinar series that should happen on the 26th of September. That is exactly 2 weeks from now at the same time. So that is when we'll really go into the details. So if there's any feeling that we may not have touched that aspect, it's because we have a whole session to deal with that. So I think this is the end of the sessions, and I don't know, look like most people are okay. They don't have questions. They are very familiar with this thing. I hope you really have made some, gained something from this session. Let me just give the floor to Dr. Mokuolu one last time, just to last final comments and experiences. Over to you, Dr. Mokuolu. If you have any you want to say before we wrap up here?
Thank you very much, everyone. It was a nice session having everybody on board. I will just add that for the post-neonatal group, as in our own setting, I think a big group is the farmers. We have to talk about their own occupational means of prevention, wearing the appropriate boots, and even taking care of themselves. Overall, thank you very much, everyone.
Ok, thank you very much. Dr. Kosia, est-ce que vous avez quelque chose à ajouter avant de clôturer la session? Dr. Kosia.
Thank you very much. It was a pleasure for me to exchange with you. And for this first session, I understand that there are not many questions, but I do hope that the next session will be more lively, and that you will share your experiences as practitioners or experts or public health professionals. So all is left to do for me is to thank you and tell you that tetanus exists, and neonatal tetanus continues to be a public health problem in some countries. And as public health professionals, we must put in place prevention measures, implement them, and especially surveillance and sound the alarm when there are cases that are notified in the system so that we can get a better idea of the scope of the issue in our countries. Thank you very much and talk to you soon.
Yeah, merci beaucoup, Dr. Kosia. Geraldine, do you have any housekeeping issues to discuss ahead of the next session before I wrap up?
Yes, I just wanted to say thank you, everyone, for joining us today for this this session. A special thank you to our panelists, of course, for sharing their valuable expertise and experience, and to our attendees for your participation. We hope you found today's discussion informative. And as promised, we will be sending out the presentation materials and the recording of the webinar to all of you via email in the coming days. The next session in this webinar series will take place on September 26th. If you have already registered for this first session, you are automatically registered for the next ones. So we look forward to welcoming you again soon. And thank you once again, and have a great day ahead.
Thank you very much, Geraldine. And again, thanks to colleagues. Just to say that the next session is going to be very, very interesting, because that is when we actually will have our colleagues be able to share their experience, because then we'll be talking about the different strategies, the vaccination strategies, the high-risk approach, where you have to give 3 rounds of conduct campaigns, all the challenges you face during those periods. We look into more details into the neonatal tetanus surveillance. We're going to look into the clean deliveries and how to monitor the indicators and all those aspects. And also we'll also be talking about how to plan and implement and monitor quality activities to ensure sustainability of elimination in countries where elimination has taken place. So again, I'd like to thank each and every one of you for your time and for your enthusiasm and interest in this global initiative and the support you have been providing and you'll continue to provide. So we hope to see you during the next session. Thank you so much. Good morning, good afternoon, good evening, wherever you may be. Thank you very much. Have a lovely rest of the day. Thank you.
Bye-bye.
Merci. Au revoir.
Thank you.
Au revoir.